hire a driver.
So, Bassel, we're here at the Brown Symposium.
Yep.
So what's the purpose of this meeting?
It's a reason to gather our alumni and friends, talk about science, talk about recent advances in the field. It's like a big brainstorming session in a nice little town, Newport. It's just an excuse to see friends, basically.
Ah, okay. It's just about friendship and humanity, right? Thank you, Bassel.
Papayas? Yeah, healthy stuff. Papaya is in charge of killing half the country.
So
So what are we doing?
did you have the time to perform your presentation?
Yeah.
It's about what? It's about what?
It's about not using cages.
Ah bon? Wow. So you're organizing a meeting about cages, and you are doing a presentation about not putting cages.
The good
Okay.
impact.
Totally online.
Yeah. It's instigating people.
C'est bizarre.
Bizarre.
C'est un peu bizarre.
Let's go eat. Did you eat? You guys eat?
Yeah, no, we didn't.
Oh, let's go.
Allez.
I want to give a little overview of the ground program. I think for the alumni who haven't been here for a few years, it'll be interesting. And I think for some of our guests, just give you a little update on what we've been up to. Maybe most importantly, I do want to thank our sponsors, our local distributors, Hip, Nerves, and Bones team did a lot to put this on, and Medtronic Orthofix and Spine Art. We really appreciate it. We certainly can't do it without them. So I want to say first and foremost, welcome to Rhode Island. If you haven't been before, welcome back to Rhode Island for our alumni. It really is uncanny, the people that are from other places, they come to Rhode Island, they just realize what a nice place it is. It is the ocean state. You guys are right here on the salt water, on the Atlantic Ocean. It's the smallest state. And I know for our French team here, 400 years of history doesn't sound like a lot, but in the U.S., it's one of the first states, and we have a lot of local history and a ton of coastline for a small state. So you're here in Newport. It was founded in 1639 on Aquidneck Island. So we're on an island. You can see that little red thing there. You got to take a bridge to get over here. Benedict Arnold was the first governor, but not the Benedict Arnold who was a trader. It was actually his grandfather. This was the state capital till 1741, and it's currently still home to the Naval War College and the Naval Undersea Warfare Center. The Navy base is actually really cool. There's some great swims you can do right off of the base. Say the base swim, you swim across the bay. And this was the city that hosted the first U.S. Open for tennis and golf, as well as the America's Cup. And we're close, for those of you that don't know, Nantucket, Long Island, Martha's Vineyard, there's just a lot right here in this southern New England region. It's a really nice place to vacation. So certainly for any of you that are not from around here, if you're vacationing, we'd love you to have you stop in if you're ever visiting. We're not close to Louisiana, though. How many people here do we have flew up from Louisiana or Mississippi? About half of them. Yeah, exactly. Not close, correct? It's not close. So in all seriousness, we're going to do a meeting down there in New Orleans, either next year or the year after. So we'll let Aaron Curtis coordinate that with you guys. That's a good class. Just so that you guys know a little more about Brown's Ivy League School, 7th oldest in the U.S., relatively small college. Our affiliated hospitals, it's a big hospital system, now well over 1,000 beds, busy place. Miriam, is Christy Cecil here? She's sleeping in? Oh, she didn't make it. I was going to talk about her in a minute, but she's not going to get her shout out. But the Miriam Hospital is where we really built our outpatient, I won't say just outpatient, but our updated spine center where we do kind of most of our non-trauma spine cases, so a big, busy place, very efficient hospital, and we just got advanced certification, so we've been very excited about that. I think all our international visitors got to come see Kettle Point, which is a really nice facility where we do outpatient spine surgery, FEOs, physical therapy, everything. And I just want to briefly talk about our history. Where's Phil Lucas? He's not there. There's Phil. So Phil, talk about, he loves history of medicine, and so do I, and I think it really is a lineage when we train in spine. You always think about who trained you and who trained them, and so we I will say, built this program based on the lineage of Henry Bowman and John Costwick, and I was very excited to see to see Dr. Kostwick out in Barcelona looking good. Yes, he said he was upset because Phil hadn't called him in too long. Tell Phil to call me. And he's doing great. So our current service is all the people you see in this room, plus a whole slew of other spine surgeons and non-operative care providers. I had to get different pictures for our current fellows because their current pictures make them look like serial killers. I don't know if everyone sees them. The pictures on the website came on. I had to find it. This is a reasonable picture. You should just use this one. I don't know where you got that other one. So we do a ton of cases, and the bottom line is that it's mostly degen in terms of numbers wise, but we certainly do a lot of trauma tumor stuff on that one slide. I don't know why, but. And a full slew and complement of every type of spine surgery that you can do. I'll leave most of this to all our speakers today. We're going to talk a lot about the cases that we do. We're using the robot navigation unit. So our research, I'll briefly mention that we've had a very prolific research team. We have a great research team that's here today, so thank you guys. We really couldn't do this without you. You're the backbone of our research productivity. I'm looking forward, Bassel, to you updating for 2024 infographic, but it's nice to visually highlight what we've done in Europe, be able to promote it to the outside world so they know what kind of work we're doing. We've been very fortunate to have a lot of really great speakers come. You know, Virginie's been up multiple times over the last year, and we had Shay and Dan Wu recently, and we've got Qureshi and others coming. So a good group of people who've been coming up and teaching us each year. I just wanted to show this briefly, Bassel, because it's really striking. If you look at this was the ISSG meeting last year, and here it is the next. And so I feel like the growth of the influence of the ISSG is matches in some ways of what we're doing here. We get a lot of residents who go into spine. I think it's just a sign that we enjoy what we do. We make it look good. We've been able to get them to match. You know, the last 5 years at Leatherman, Utah, you just has Hopkins and San Diego. So I think we have good connections around the country that we've built. We've got a lot of upward trajectory. We've been expanding into other hospital systems. We became an Spine Fellowship. We've doubled our ISSG membership. We hired a research army. We've had a huge growth in case volume. A lot of industry partnerships. Yet again, we really appreciate our industry partnerships. It's not just a conflict of interest, it's our ability to have meetings like this and spread the word. We're building our prominence in the national societies. We've had these great international visitors. Powell came this week, and Dr. Wu as well. But we've had the French contingent there with Vincent Challier, Khalife as well in the last year. And we're expanding that down into Fall River, so we're also building our local footprint. I will just say too, if you look at our trajectory of applicants over the last 10 years, Aaron Curris, we've grown more than the Dow and S&P 500, had 443% increase in applicants in 10 years. So I think we're doing something right. So with that, I'm very excited to introduce my friend, Dr. Diebo here, who's going to talk to us about not doing interbody cages, which I don't think the industry people like this talk, but very good. Thank you.
So not using interbodies for realignment. So if you look at the literature, it's really replete with the use of interbodies for fusion purposes for biomechanical stability. And it's established that you get better fusion rates at the lumbosacral junction with it. Although some data, I mean, some of the papers out there, you see an ample of interbodies in the lower spine with rod blade issues down the road. So as I was traveling around the ISSG fellowship, I noticed that some of the surgeons rely on interbodies, some of them actually don't, and all of them have successful outcomes. So bottom line is, if you want to use interbodies, you can. And you will achieve anterior column stability and fusion, but also you can do everything posterior in terms of third equivocation, possible siotomies and releases of the spine to correct it. So, this is one of the studies we looked at with the ISSG, looking at, the title is MIS versus open, but really it is anterior column interbody fusion versus posterior only fusion. And you notice the fusion rate right here. For the MIS, or let's call it the anterior column fusion, is about 66% versus 89% for the posterior only. If you say any fusion 360 and assess MIs versus open or interbodies versus not, they end up being equivalent to upward of 85 to 90%. But basically, this study shows you that you can achieve fusion posteriorly without interbodies. And just to highlight here, it says 7% for posterior fusion in MIS, but actually they didn't aim for the fusion posteriorly, they actually just did perfect. So that's one way to look at it. And we kind of walk away from talking about using implants and instead of trying to understand where to put the implants, in what zone of the spine, and how to understand where to stop and how to stop there. So I think, in my opinion, it's more important to understand your UIV zone and LIV zone in terms of multiple factors that will allow you to prevent your mechanical complications. So it's not really about cages, it's not really about the implants, it's about where you're instrumenting. So we propose a concept called the landing zone. Basically, you look at the zone you want to finish your construct, whether it's in the top or the bottom, and you understand it from multiple standpoints. Most importantly to me is in the hospital units and bone density there. There's a lot of studies showing that 125 is really your criteria to stop any fusion and place your UIV. The second thing is sarcopenia and muscle quality. If you're going to stop at a zone where there's a lot of fatty infiltration and there's a lot of muscles are not adequate, you want to think about whether it's a proper zone to land, or if you want to supplement with ligament augmentation, like others in the lab. In addition, I mean, we rarely look at, for example, if you're doing a T10 pelvis or a T10 L4 or a T10 T2, we rarely look at the level there and assess it for like prosthesis or degenerative disease or asymmetric disc collapse. There's really subtle findings on the X-ray that will allow you to say, well, I don't want to stop there. Look at this. So the study we did with RSG to look at that were basically a bunch of T10 pelvises, and we looked at the baseline X-rays before the fusion and assessed that zone of landing. And what we found is, 30% of patients that had a T10 as a UIV had a T9, T10 prosthesis, subtle grade 1 prosthesis. It means nothing in global safe spine, but it means a lot if it's at the last instrument level. So you might want to bypass it, you want to stop somewhere else, or we want to consider a shorter fusion or longer fusion. So what we found is if you combine this, variables, which is where the UIV is in space in terms of translation, plus the elasticity, plus the bone quality, you notice that the PJ rate is extremely high if you don't pay attention to those things. And this is an example of a patient that had a baseline elasticity at T9, T10, had a UIV at T9, in addition to the overcorrection. That was the recipe for this test we done. So I'm going to put some case examples. There's a lot of live voting in it. So we'll hear people speak out. Please feel free to raise your hand and talk. If you want. So this 75 female scoliosis, worsening back pain, OBI is high, everything, usual stuff. No issues. She was on Prolia for many, many years. She's really thin. She's BMI 20, so it's your dream. And this is her X-rays. So this is an adult idiopathic scoliosis with kind of on the severe side of L2, L3, L3, L4 lateral prosthesis. Sizable lumbosacral curves. Sagittal plane, she's okay, and this is kind of the way I try to do it. It's called segmentation, and you notice that the lateral plane has also the segments, and you notice it's 33 degrees up at 4S1, reasonable at 103, and then the thoraco-lumbar junction. This is her CT scan, and this is what I mean by the Hansfield units. We measure it through this ROI or multiple tools in the imaging center or even PACS. Notice how her L4, L5, LIV, the mean is the number, 211 and 166. This is well above the osteoporosis threshold, so we're good there. Is it a bending note? Here's a vote. So what are we doing? And forget about the options, you can see what you want. No radicular symptoms, just pure back pain.
It tells about her landing zone in the thoracic. I agree. Yeah.
Landing zone is fine.
Okay.
Well, which leg?
Both of them, four and 10.
Both are good?
Yeah.
Okay. I'm with three.
I mean, I think you do have to be careful with T4 that she's got this upper thoracic kyphosis somewhere in there. I can't count right at the moment, but meaning I think T5 or T6 would be very bad. Maybe 4 is good, but she might be someone 3 or 2 is a little better. Do you agree with that, Virginie? She started that kyphosis. Well, you count carefully.
Mike, what do you think?
I agree. I think 3. I thought a little bit about 1 as well. I think she does have some deformity up there, hypokyphosis through her sort of thoracic region. But I also worry about what would happen after that, and she would sort of fall forward. And so I probably would land on. I probably would do. Since I am giving the ALIF talk here in a few minutes, I should probably think about an ALIF. But a TLIF I think is fine as well. I probably would go with T10.
Would you ALIF for stability, ALIF for fusion, ALIF for alignment?
All the above.
Above?
Yeah,
Supine?
yeah.
Not on the stuff.
Yeah, ALIF in L4, L5 will be a powerful tool to correct the coronal deformity.
What do you think about the L4 to small lordosis being 33? What size ALIF are you going to do with lordosis 1?
Yeah, 33 is good.
33 is good, so if you put a 4 to 5 ALIF, what size are you going to use there?
Yeah.
Okay.
No. Kind of not hyperlordotic. I use ALIF L4, L5 in this case to correct the coronal plane.
So a small lordosis, about
Yeah.
10 or so. Okay. Francis, if you said.
Well, I said your point about you're putting 5 up there is an interesting one. Just because her disc is big, the 5'1", she's like relatively sagittally balanced when she stands. So, and how old is she again?
70 something.
Then probably wouldn't work good.
Yeah, she's on the older side.
Yeah.
She's not frail, but the usually shoes.
For me, I would. Sorry. Yeah, for me, I would choose the second because I would do TD from 3 to 1 to S1. So firstly, I think T10 is enough. Although there's a little kypho at the thoraco-lumbar, but T10 should be enough because you already have enough lordosis and kypho. It's kind of relatively balanced for 70 years old female, right?
Yep.
Another thing is, I think that 3, 4, 4, 5 TDF is really to correct the chronal imbalance and to do kind of indirect derotation rather than kind of restore of the lordosis. 5-1 is really to help to fuse, we're gonna have a solid fusion rather than restore the lordosis because the kind of L4 to S1 kind of lordosis is relatively not that bad, right? So that's the reason why I'm gonna go to a T10 to pelvis and 3 to S1 TD.
How about neurosurgeons? Raphael, what do you think?
I mean, I think you could I think that T10 is a good level. But then, yeah, the question is, you need to add interbodies or not. I know your talk is against using interbodies, but I mean, she does seem to have good bone quality. Maybe you could get away with it, but I do see the value though in the T-lifts, right, for the correction of the coronal plane. So
if
2 or 3.
If this patient had a BMI of 35 instead, do you think are we talking about the difference between somebody who's small and has a BMI of 20? And so, at what point is interbody maybe the question about whether or not it's interbody dependent on the size of the patient?
If you're asking my opinion, I don't think there's data on the BMI versus the interbody and the ability of interbodies to overcome the BMI for fusion. But I'm going to let Bryce talk on that. If we're going to talk about the little thing that's both TLIF that we put in the back, and then on a 220 pounder, and I always think about it. You guys know Vincent Challier paper about overpowering posterior instrumentation. So we can overpower posterior instrumentation with an ALIF cage. Do you think the patient cannot overpower the interbody with their body? I mean, I think they do. I think there's eventually the interbody. If it's a TLIF, it's a lateral and big cage and epophyseal, contact maybe, but I don't know. So yeah, she did T10 pelvis and lower bodies. She's almost a year out now. But yeah, I mean, in terms of TLIF and the correction, you know, the way at least I personally do it, if I feel that, you know, after the osteotomies and the posterior releases that I have the segments derotated and established in the groin plane, then I know I just don't do TLIFs. Just focus on the posterior approach.
Yeah, on some of the beautiful mastectomies, like what level did you do those?
Everything. T12 all the way down.
Something I always wonder, like, if I truly chop the sets out, I try to bone graft, and it all just falls into the canal membrane. So, and I talk about this a little bit in my talk, but like, where do you get the fusion in a situation like that when you just take all the posterior elements out?
Did you do a sublaminar? Did you do a sublaminar?
No, not this one. No, but if I do midline decompressions with this, it's sublaminar these days, so I don't take the lamina off. And also I decorticate the lamina from the spinous process, so you peel it off like the BD way. And the gutters are also packed. And I've been using, I'll show you, there's a video, I'll show you some of the program stuff that we do.
You did the tether suspicion.
Yep, I tether everybody, I just don't want to guess if does it work or not, because it works at least multiple data sets. Not the one level, this is 2 levels above the UIB, and then the UIB level and the UIB -1 level, so it's about 4 levels of tether. And it's really efficient, it doesn't take much of your time. You know, just work through the spinous process base and you pass it, you know, the fellows show that, and pass it over here, so it's fine. All right, one more? You have time? Yep.
Yeah, you're good, it's 6 minutes.
All right, cool. So for female adult, you're going to be back, so it's the same thing. BMI 34, here we go, here, right there. Mostly central. And those are really main crazy issues. So the I-45 mass back extend, and this is a curve. Again, it's adults, idiopathic scoliosis, lumbar apex L2, some L2, L3, L4, L3, L4, lanostesis. Not so big for a swan fractional curve. Sagittal plane, also 37, 13, 22. Not too bad, yeah, 56. No sagittal sugar. This is her. She does have some parietal stenosis around the apex of the curve. Some on the right side, some on the left side. She does have some reticular symptoms. Shooting leg pain down the thighs. Actually, it alternates between right and left. Good bone quality, all plus 200s and Pascal units on every level from T1 all the way to bottom. She's got, although you know she's 55 female, but you know no osteoporosis whatsoever. There you go. Dr. Wu can comment on this.
Yeah, thank you for showing this case. It's a little bit yesterday. It's a fantastic case. So previously we talked a lot about the kind of etiology or diagnosis for this patient. Given that there's like one kind of main curve at the lumbar and then another compensatory curve, this is really kind of scoliosis derived from idiopathic one rather than de novo degeneration scoliosis, right? So in that case, I think the main correction comes from the correct lumbar, and then in terms of the upper compensatory curves, as we kind of discussed, I think T10 should be enough because there's a little thoracokyphal and not that severe like flat back, and then so multiple PCOs, and for me I would still do kind of interbody fusion. It's at least a 5-1 because by doing that there's kind of 360 fusion. It's kind of solid fusion in my head. So,
yeah, I would just say one of the reasons why many people migrated to interbody 5-1 like Lanky was that the rates of rod fracture and iliac screw loosening or sacral screw fracture were higher over time. And it depends. If you put 4 rods and a bunch of BMP, a lot of patients will be fine. And so I think the short-term outcomes probably be identical for a patient like this with like 3 versus 4, you know, no interbody, A-lift or T-lift, but it's maybe the 2, 3, 4, 5-year follow-up. It may be different.
Yeah, so the data from Gridwell, the original, the grandmother of papers that showed the pseudo and I find one that everybody down the road started doing T-lips, including Larry and all that, is clear. There's some data against that. There are some practices that, incubation practice, for example, is going to be years follow and without issues and pseudos. But yes, you've got to be spending a lot of money on B&B, basically. So it's either or.
And you gotta take the time to find places for bone graft, as Aaron and others were saying. You gotta find the ALA, find the L5GP, and really decorticate and put a lot of bone down. You can't, as you guys know, I'm not always thorough about doing that. But if you do a good interbody, you may not need, not always, sometimes. You may not need to get as good a post-dural fusion final to do a beautiful TLA or an ALA. You don't even need to expose 5-1 with the S1 ALA. If you do an ALA, probably.
Yeah, true.
A different technique. The fault of this patient is what, 12 hours?
Yes.
13 hours. 13 hours.
It's spooky.
No PJK.
I don't have PJK. So this is basically the posterior column osteotomies, and also on the left you see the actual PCL. I'm cutting the PLL with a knife. Just one level of full posterior column. The rest is osteotomies, and this is sublaminar decompression.
That's our best resident program too. So.
Yeah.
He looks very engaged.
Yes.
He's going into sports.
So this is after first, I did bone graft in multiple layers, first for the rods, and the second rod, and the third rod, and the fourth rod. And I was in between them, BNP in the right bottom, and then after bone graft. I just wanted to show, I used femoral heads, crushed, the old-fashioned mill, and BNPs. And I also do bone marrow aspirate, so it's about 50 cc's of that, plus the bone graft.
I'm glad you're showing this. Actually, I need this talk for ISDS. We're going to talk about bone grafting. I mean, this is exactly the point, is that you're grafting in a way that's very different than I often do. So that's what you have to do if you're going to get all posterior fusion.
Yeah, it's a one day. I'll present it next week.
You can present it every year. Looks pretty good.
Yeah. Just wanted to show the foramen here for the decompression. You notice if you actually establish the segmental derotation correction, you can hit the foramen out. So don't worry about intermittent radiculopathy. Of course, the severe one with that's hypertrophy and that stuff. With the IFPs coming out and you look at the SAPs, I can do some decompression as fast and decompress.
Phil Lucas taught me that. I mean, he didn't do open lames and any of these scolies, right, Phil, that had intermittent stenosis, because you said, straighten the spine, that'll be fine. Just help the foramen and recess a little bit.
Also, no, that's correct. The line fusion technique, I think, that's really what you're really trying to accomplish.
Yeah. I'm hoping we'll see what happens.
So, Basil, what's the graft combo that you said you use again? You said femoral head allograft. What else?
It's 3 femoral heads, 4 T pelvis, and one large bit of BMP, and the bone marrow aspirate. So I take the S2AI whole after I tap it, I put a needle in it, and just aspirate.
Yeah.
All right, there was another case about with the 1 year follow-up. I'll show you quick. Anyway, this is just double measure curve. Some prosthesis, L3 and 4. This is 5 sacralized. Council units at the bottom, 122, 100, 3/4 back of the disc. And then use, this is 1 year. So.
That's really good. Go back to that. That's a really nice job. Pretty good. You should last that patient a long time, I think.
How old is the patient?
55.
Beautiful.
Thank you, everybody.
Good work.
Thanks.
And I think it's a lifetime of work because there's a lot of people who still don't believe in it or don't want to focus on it. Our job is to keep sending the message. So we're going to do that today. There you go. All right, thank you, Virginie.
Thank you. And this is also going to be an introduction to French accent, because that's what you're going to get later on today. So I'm going to talk about surgical planning in setting of degen population. So, surgical planning, historically, was more on the complex, disaster case. And I think we didn't do a good job at spreading the word. In the sense, right away, we presented some terrible case with revision surgery, and then the mind of people was okay, you have those crazy surgeons that measure everything, but it's not necessarily applicable to the degen population. So this is an X-ray, I believe, either from Alan or from Bassel. So maybe you have two categories of people: the one that do not believe, and then the lunatic that put so much light on the X-ray that you cannot see the vertebrae anymore. So let me give you a little bit of background. So this is an ISLG study from Bassel and Alan. Basically, we looked at a very complex deformity database, and then we realized that 50% of the patients are revision surgery, so very classic. But then 50% of them are iatrogenic deformity after degenerative fusion. So altogether, the short fusion, they do represent 25% of our severe complex deformity. So this is kind of a big deal. And you can say okay, this is just radiographic parameter. Then we ask the surgeon, what is the reason for revision? And in the vast majority of the case, it was formal alignment. So on one end, you have the clinical presentation, and then you have the surgeon input of why do they do the revision. So that's number one reason. The number two reason is that when you fuse a patient by a few levels, 1 to 3 levels, we don't realign them. So this is a study from Quebec that showed that those patients are malaligned in 30% of the case, and after the surgery, they are malaligned in 28% of the case. So you as a surgeon, you went through the work of doing posterior fusion, interbody fusion, and the malalignment is still there. And now there is starting to have a significant amount of the literature that show that you can have advanced adjacent segment disease. So I'm not talking about the sign that you see on an X-ray or maybe some bad MRI digital disease. I'm talking about adjacent segment problems that are so bad that those patients require revision surgery after 1 to 3 level fusion. More recent literature show that it's okay, not only you need to restore the lordosis, but you need to restore the lordosis at the right place. Number 3 reason is that when you plan, we usually get what we plan. You may change your strategy during the surgery, but the alignment that you plan is usually very useful to achieve your objective. And this is some X-ray from that Bassel and Alan gave me. That's not their case, at least that was the same. But this is some X-ray from LinkedIn. I mean, we don't even need to measure them to see that, it seems to be suboptimal. Look at those ones. You can put them in a museum of a bad alignment. Again, you don't even need to measure them. So the surgeon went to the work of doing a posterior fusion and interbody fusion, and then we got those disasters. And so there's a perception that when we talk about malalignment, we want to push everybody to do a T10 to pelvis fusion or T4 to pelvis fusion. That's not the case. The case is that you as a surgeon, you decide which level need decompression, stabilization. And then the point is those levels that you're gonna fuse, we need to align them. We're not pushing you to do more and more levels, just focus on the clinical need. So what we also found is that iatrogenic deformity can become a disaster, a complex deformity, that the literature supports the association between malalignment in short fusion and the risk of revision surgery, and that overall we're not doing a good job. So what is surgical planning? Surgical planning is not telling your rep, I'm going to do a L4-S1 fusion with an ALIF. That's booking sheet. That's not planning. So planning is that you have to evaluate your patient. You have to think about how much you want to realign the patient. Then think about what is the strategy that you're going to use to achieve the goal. And then we also need to monitor. If you're planning your alignment surgery, ideally you don't want to wait that the patient stands up to say I missed the goal. Ideally you want to monitor that during the surgery. So let's go over the step. So step number one, you want the pre-op evaluation. So this is a case, I don't know, either from Alain or from Bassel. So this is a 73 male patient with a progressive low back pain, obviously that didn't respond positively to conservative treatment, and bilateral radiculopathy. Do you add anything to this case? On the clinical condition?
No, what you just said.
MRI showed that the patient needs surgery. I'm an engineer, so I'm not going to over clinical. And once again, the level that you're going to fuse are not dictated by the X-ray. They are dictated by what does the patient need. These are the flex X on the left and the standing lateral X-ray. Who wants to give a shot at interpreting those numbers? Vincent?
Yeah.
So PI 51, L1, L4 38, L4, S1 18.
What can I see? I can see beyond the number, the shape of the basement is kyphotic, and we can see that there is maybe it could be a compensatory mechanism above the kyphotic basement, maybe represented by the degen spondy. I mean, biomechanically, obviously there is a problem in the basement.
Yeah, so the first thing I would say is when you look at the X-ray, it's weird. And the notion of weird is a very important one. You would say talk about harmony. So harmony or qualify harmony. When you look at the X-ray and you're there is something wrong, I mean that probably there is something wrong. So we're going to go back to this case and to interpret those numbers
Can I add one thing? This is why PILL has failed for degen work. So when Virginie and Frank and others started looking at PILL for spinal deformity and doing T4 to pelvis, PILL works pretty well because you just need enough lordosis to place the thoracic spine in space over the pelvis. The reason it started to break down over time is when we started realizing alignment also matters for lumbar fusion. This patient's PILL is normal, but they have a highly abnormal spine shape. The problem is, as Bassel says, the fused spine and Virginie is not the same as a mobile spine. So if you fuse the spine right there from L4 to S1, you suddenly have a very stiff, malaligned 4 to 1. And you still may have a normal PILL right after surgery, but you're putting a tremendous amount of force on an abnormally shaped, abnormally positioned L3-4. And so that's why PILL mismatch does not work for this patient. Because 5 years ago, 10 years ago, or a lot of people out in the world now go, oh, look at the green at the bottom, PILL is fine, it's good. Just put in some cages, get her decompression, she's going to love it. She actually may love it for a little while. It's not going to work. So that's why you got to think about regions and segments.
Yeah, so if you don't know how to interpret those numbers, green is good, yellow is so-so, red is bad. So basically, for the next slide, you have the answer on the color code. So now, we evaluate the patient, we evaluate the images. Let's evaluate the number. And so there's two approaches, and French army mainly with me because I went to the dark side of the ocean. I'm working in the US, so you have the Rousselier approach that say we need to think about shape, and then there is the US approach that say let's think about what matters from a clinical point of view. So if you're not familiar with the Rousselier work, it's basically you want the lordosis to be proportional to the sacral slope, and you also give us some information of the apex of the lordosis. The reality, and this is like the Schwab approach, where it's like there is nothing normal with the spine, and even less normal when you do fusions. What is normal to have like 12 screws in the spine? And so our approach was to say like, we're gonna come up with some parameters that correlate with disability. And the reality is that you can combine the framework. So you can like restore the spine, the shape of the spine, while still plugging some of those numbers. So here are like the Scully film for the same patient. So kind of like a same interpretation. You can drop a plumb line to see like does it fall like over the sacrum. So the plumb line I'm using like 3 grade. Plumb line from C7. Over the sacrum, good. Between the sacrum and the femoral head, so-so. In front of the femoral head, bad. So that's why I love the plumb line, because you don't need to measure it. You can just like look at it. Something on this X-ray is like, look at the lordosis, like it's very, very long. So it's almost like the lordosis goes like up to the middle of the spine. So again, this falls within like the weird category. What do you think of?
Yeah, I want to comment on the normative versus age-adjusted approach. If you go back to your slide, Virginie, and I think you touched on it, but what this basically means, and I thought about it for a long time, and that if you take a normal spine, no issues, and put rods and screws in it, that doesn't mean that the rods and screws and the construct will behave in the phase. So that's why the alignment adjusted by age basically gives you a construct that's not necessarily normal in curvature. It's a bit undercorrected, but it's more biomechanically favorable to shoot for that than normative value.
Yeah, and this was mainly derived from complex spine. And at the beginning, we're like, okay, let's publish that. And then we thought about it a little bit more. When you have a complex deformity, it's not that the deformity happened like overnight. Maybe it took like 10, 20, 30 years. And then you put those patients on the table, and within 4 to 8 hours, you totally change the spine. So they went from like this for 20 years to like this in a few hours. And maybe there is something like in the brain, like if you are used like to be malaligned like for years and years, like maybe it changes like your proprioception. So we don't actually know very well like what is the comfort from a patient. So maybe that's one of the results we don't know.
Yeah, I mean, I see that really on a daily basis in terms of undercorrection and alignment and impact outcomes. 75 years old, undercorrected with age-adjusted threshold are so happy. They have no idea that there's life better than this in terms of alignment. So you already brought them from, an SVA of 180 to SVA of 65 or 70. They are so happy. So I think this actually driven by prompts. It came back from ODI and SF36 to give alignment thresholds, and it gives it back to the ODI. So it's really solid.
Okay, now you need to stop talking because I still have 20 slides. So how do you evaluate a lordosis? There is no magic number that is going to save your life. It's a process. So the process is that you want to evaluate like the global lordosis, like the PI-LM mismatch. Then you want to go like by region, proximal versus distal, and then segmental lordosis. Again, you don't need to do that on every single patient, but if you're going to fuse the spine, it's starting like to be relevant. So PI-LM mismatch, overall, if you have an average PI, PI is a morphometric measurement of the pelvis, you want to match a lordosis in the PI. Very simple, same number. If you have a small PI, you want the lordosis to be a little bit bigger than the PI. A large one, a little bit smaller. So it's a very simple framework. You may have the rule like lordosis should be within 10 degrees of the PI. This is what we mean. So you can tailor that, the amount of lordosis based on the PI. Rule number 2, when you go now to regional, meaning like L4, S1 versus L1, L4. This is a study that we did like a few years ago when I was still at HSS, and we found that in this small group of asymptomatic subjects, L4, S1 was equal to 35 degrees, and deformity of the PI. So at the beginning we were surprised, and then we were super happy because we're like, well, that makes our life like super easy. This is like small PI, 35, average, 35, large, 35. So that's easy to remember. What is happening is that when the PI increases, the proximal lordosis becomes more and more pronounced. Look at from about 16 to 30 degrees. So as the PI increases, you want more and more proximal lordosis. And the next step is to go to segmental lordosis. You know, if you're planning L4 S1 or L5 S1, you want to know like how much you want to put at each single level. So this is paper from Alan and Bassel that are based on the French literature, where they collect like a bunch of asymptomatic subjects. And so Alan and Bassel, they're super extensive, so they give you like the alignment at every single level. But let's look at like the last two columns, 4, 5, 5, 1. If you add those two numbers, for a PI going from 50 to 80, you add them, it's about like 35 degrees. The thing is that if you have a tiny PI, like you need a little bit less lordosis. If you have a huge one, you need a little bit more. But overall, it's like 35 degrees, and in the extreme case, you need to think a little bit more. So again, this makes our life like super easy. So let's go back to this case. You know, this case is an average PI, so you want 35 degrees, 20 at 5.1, 15 at 4.5. So when you start to plug the number, it means that we need to increase the lordosis by about 10 to 20 degrees at those two segments. Okay? Any question on that? Because this is like the key of surgical planning in the Degen case.
This patient has a little bit of a lumbosacral counting anomaly. How do you, when you're measuring these, take that into account? Where do you make the sacrum?
So usually I make the sacrum on the level that is the first disc above. I consider that as being 5.1. Okay. And then I just apply like the rule that we talk about. Because it's not like there's a lot of literature to guide you. So I'm like, this disc is the first one mobile, that's going to be my 5.1. So now we know, we evaluate the patient, we have an alignment target. The next step is like, what's the surgical strategy? I'm going to talk like very briefly about the flexibility of the spine. So at least on the adult side, like we use supine film. So it can be supine MRI, supine CT, supine X-ray, whatever is available. So this is a case where you see like just by putting the patient in supine position, we gain like 10 degrees of additional lordosis. So the flexibility part is actually part of the surgical planning. So going back to the same case, if you look at like the flexion and extension, we see that the proximal lordosis is flexible, so 38 to 20 degrees. But the distal one is kind of fixed. So it goes from 18 degrees or something like that in standing to 20 degrees in extension. So you cannot rely on the flexibility to correct your forward. So if you plug all those numbers, like we see like we need like to evaluate to increase like the lordosis at each of those segments, but you need also like to take into account the shape of the vertebra. That's something like until recently like we didn't take this into account. So very often you're gonna have like your L5 vertebra that is already lordotic, and then as you move from L5 like to the middle of the lumbar spine is kind of parallel. The proximal part of the lumbar spine is kind of like aphotic. So think about that when you started like to plan your alignment strategy. The next step is like to control during the surgery. So you can use some fluoro, you can, I don't know what technology you have in your hospital, but this is like the poor man technology, and some people have access to the fancy imaging. But I think it's really important, because you want to match your plan, this is a different case, to whatever is being done during the surgery. Bassel or Alan, do you want to comment, or do you want me to do it?
No, you do it.
So, I need to put my glasses. So here like, you choose like to correct like the segmental lordosis with some AF. And something that is very important, like when you put your AF, like if there is, or when you prepare your disc, you know, if you change the shape of the vertebra, then you need to adjust your cage. Okay? So what was done here is like there was a plastic deformation of the L5 body, and as such, they decided to put a more robotic cage than whatever what was planned. And then they measure it. The L4S1 lordosis was like 38. Remember our target was 35. They were very happy with their job. They congratulate each other, and they close the patient.
Yeah, the only thing I'd add, I like ALIF because it allows me to deliver the amount of lordosis I want in a very reliable way compared to TLIF, where in my hands it doesn't. And I do measure during surgery, you should be measuring calf angles in my opinion. And we didn't even know how to do it, at least I didn't until Bassel was out there. He was, oh look, you can do it on the CRs. But it's really, because before I was just guessing, you know. We measure all the time, 4-to-1 lordosis constantly on the table if you're going to do a 4-to-1 fusion, and it's very helpful.
But the key is like if you need 10 degree L5S1 and you already have a vertebral body that is 10 degree, then you just need the disc at the end of the surgery to be 10 degree. Okay, not all the lordosis is within the disc.
Exactly, there's some measurement because there's patients who already have 10 degrees and you need to get 10 more. You actually really need to measure what you're starting beforehand on the standing x-ray, where you need to be on a post-operative standing x-ray, and add that, and it all depends, as she said, on the shape of the vertebral body as well.
And so here, like the distal lordosis was restored, like so the two ellipses, and as a consequence, you have some relaxation of the proximal lordosis. So you kind of like have a flattening, and that was expected. And this is the good news, because now like the proportion between proximal and distal is something that will actually be better.
The only thing I know on the pelvic screws, I gave the similar case at the Rothman meeting, and the question was, Alan, why are you putting pelvic screws in everyone? I said, well, I don't put them in everyone, first of all. But for me, the reason is to make sure to maintain this alignment over time. You can take them out later, but I've had some patients where you get a beautiful realignment, and then just the sacral screws plow a little, and the ALIF subsides a little, and then just slowly go forward, and you measure your 4-to-1 lordosis in 1 year, and you've lost 10 degrees over time. So I prefer leg screws. I believe the downside is extremely low until they get solidly fused. Maybe if you want to take them out later, you can, but I haven't had to even take them out. So
Yeah, especially, go ahead. No, it's
anyone can.
I was just going to ask, pelvic screws, I probably would have not put pelvic screws in here, so I guess the question is, does your, do you use it in everybody? So it's not really an issue? Or is there a difference if you don't do any interbodies, in a particular case? I'm interbody-centric, but sometimes you don't or can't for some reason. Do you need pelvic instrumentation in that situation because of that? Or are you more likely to do it if you're going to do a TLIF? Is there a difference in any of those, or is it you just sort of use it?
We're going to study it this year. We're going to look at all our data. But for me, impaired bone quality, substantial change in L4 to S1 lordosis, or really big ALIF, I'm just going to put it in. If you're doing a 30-year-old work comp patient, you're doing a 4-to-1 fusion, male good bone, whether it's TLIF, ALIF, no way I'm putting pelvic screws. This is a osteoporotic or pre-osteoporotic woman who has substantially changed the shape of her spine.
I think it also matters if you're doing MIS or not too, because I think if you did a 4-to-1 ALF perk screws here, there's probably a lower likelihood, I would imagine, you're probably going to get as much subsidence because you're basically maintaining all the posterior musculature, right? And so again, I do a ton of indirect decompression, anterior posterior. Just in general, I think by not stripping off all the musculature and all the stabilizers and the PLC and all this sort of stuff, you're maintaining that tension band and you have a little less subsidence.
I mean, that's assuming that the baseline is good, but in those cases, and especially if you think, iliolumbar ligaments and ulnar ligaments around in the spongy setting, they're lax, they're not great. So that's what connects the lower lumbar spine to the ilium.
Yeah.
So I wonder if there's any common variation that, now we guess it, but whether, kind of modeling anatomy with the lower body.
Yeah, and I asked, one of the studies that we did at HSS was to evaluate, where does the loss of lordosis come from? And the vast majority of the time, it kind of starts with the proximal segment, and only when you become super bad, it extends to the distal one. And I was so surprised on this data that we repeat another data set, and at one point I'm like, oh no, we have been something doing wrong in the past 15 years the way we measure it, because I couldn't believe it. You know, most of the time we think about loss of lower as being like L4S1. And so when I don't understand something, I ask Dubousset. And Dubousset is like, yeah, it makes sense. I'm like, well, you need to elaborate. Like, and for him, like the role of the iliac ligament that we never really studied, maybe has a role in stabilization of the distal segment. So that's more a question mark than an affirmation. That's something like maybe on point we need to investigate. And I have nothing smart to say in my conclusion. I think we cover already like everything.
I just want to say that, you know, last year we presented the segmental lordosis this year as well. And, you know, for some people it might sound like an academic exercise, or it might sound like something like doing too much. But I think we're going through an era where, you know, at least what we know that the AO is on board right now.
Yes.
There might be guidelines coming out, and when AO presents guidelines, then the insurance companies might go and say, well, do you follow AO guidelines in doing your surgery? So I think this is going to become very real very soon. So that's why I decided to kind of touch base on that again.
Yeah, and again, this is not about like fusing more level. This is about like we're aligning the level that you're going to fuse it anyway.
Thank you.
Thank you.
From Europe. So the spine research community is a very exciting initiative that started a few years ago in France by Vincent, François, and the team. And they kind of end up being about 47 surgeons in France in about 30 centers. And they perform about 15,000 surgeries a year. And they found ways to kind of collect this and they found ways to collect data through, especially EMR they have to follow. This EMR is an EMR and a data collection in itself at the same time. So imagine a Athena that we use that doesn't have any capability to collect data, but we use it as EMR, so that's why we use something else like Uber or whatever else. That software they have has the ability to do both, which is kind of very interesting. Allow them to streamline the data collection in a way that they don't have to put a lot of efforts in it, because that's the whole problem with efforts and benefits of the surgeons. So I invited them this year to, they're trying to utilize their data for a lot of really useful initiatives about AI and endoscopy, and we're going to hear a lot of talks today about how far we can go with endoscopy.
Hello everyone. We are very pleased to be here, thanks to Bassel and Nan. And we represent here the spine research community, as you saw. So we are talking both, Joseph and me, about UBE, Unilateral Biportal Endoscopy. And we'll do something like Lauren and Hardy together. So
I'm the bad cop.
We can tell.
Yeah. So we won't show you data now, we will show you our journey, because we start a journey together in Unilateral Biportal Endoscopy, and we will show you the panel, the entire platform we can create around it, but behind there are a lot of data as well, but we won't talk about it right now. So this is spine endoscopy. This is something huge, I mean invasive. You are targeting the pathology, usually the compression, but we will see that it will be even more. You will forget about blood loss. We will forget about leakage in post-operative. We are almost on 0% of leakage. You will forget about infection as well. So the two most anxiety of a spine surgeon. You can lift them backward. You will decrease pain after surgery, decrease the painkillers intake, have better hospital stay, better and enhanced recovery after surgery.
And I have to talk. I have to question François. What does UBE add in the playground of a spine surgeon?
So for those who are not common with biportal surgery, you see that it adds much more vision to the field. You have a wider vision like you have in open surgery or microscopic surgery, but you also be inside the patient, of course. So you put your eye into the patient. You add dexterity respective to the monoportal or uniportal surgery. dexterity, so the use of 2 hands or even more, if you need, into the field.
François, why? As to your group.
No, actually, the point is that it's not a string to our bow, it's mostly the entire bow we add and the target. It means that we change completely the way we think spine, the way we think our strategies, and the way of doing our surgeries.
So, if I understand, it's not a technique, maybe it's a platform. Yes, it's your new world, but let us discover your new world first.
So we will show you the panel and the possibilities of surgery in the field of UBE. So let's go to the operating room and see how it works.
Yes, first we have to understand what's UBE. UBE is unilateral biportal endoscopy. We can use 2 incisions, and in the left incision you can have your endoscope for a right hand surgeon, and in your right hand and the right incision you put your instruments, and the same instruments like in the open surgery.
And thus we have to change the position where on the side of the patient regarding the pathology we're treating?
No, if we are a right-hand surgeon, we can stay always at the left side of the patient, and we can have always the same positioning of the patient in the OR. The positioning is always the same. It's a prone position, like in a usual surgery, and we have a zoom on the interlaminar approach. We can, after, see the screen on the column, the arthroscopic column, the same like the orthopedic surgeons, and we will see this kind of image with the superlaminar, inferior laminar, posterior joint and spinal process. It's important because you have to integrate this to the understanding of the video after. It's a normal speed. I'm not a Parkinsonian people, but it's just to see the working space. It's at the beginning you have to create a working space like a small aquarium to have to see your supralaminar, your yellow ligament.
And so can we standardize the technique regardless of the pathology and do it all the time the same thing or not?
And we can have a standardized technique with a step-by-step technique, and it will differ depending your surgery. For canal stenosis, you have not the same step like than for the anal disc, and you can, if you want, to see this small paper to begin, if you want, you will technique. And François, what kind of pathology you can?
So let's proceed with all the steps to do all the panel of surgery. So we usually start by microdiscectomy. It's called micro, but it's endodiscectomy actually. And as you can see, it's a bimanual. It's with 2 ends. So you have the field of view on the right side, like you have in microscopy actually, and you have the same movement of the ends. You have the complete independence of movement in between the 2 ends. Usually, then you proceed with lumbar canal with foraminotomy after microdiscectomy, and you can do extra foraminar approaches like the Wiltse we are common with the tubular surgery, or like the MIS TELIF. And then we can step forward with lumbar canal stenosis. Usually we start with the soft one, then with the bony stenosis that are harder in endoscopy. And going into the world of biportal endoscopy, we start to understand that we are even safer than in open or microscopic surgery. There are many steps to respect, to do like the butterfly challenge, which is all of the bony work with the drilling until the complete remotion in one piece of the yellow ligament. It's not only a challenge, but it's something even much safer for your surgery than for your patient. For decrease about 0% of dual tear and postoperative compression. We can treat, of course, with more confidence in stable patient. I mean, we're going to be less iatrogenic on the spine, so we can, if the clinical aspect of the patient is only a neurologic compression, we can go into without too many fear about it. Then you can see that it's not something that add you vision, it's something that bring you into a complete other world, because here you are on the contralateral foramen without having performed an arthrectomy. You can see very well the exiting roots into the foramen, so you have a wider vision, even more than conventional surgery and microscopy. And then we can proceed with fusion, what's called hybrid. It means that we are going to do first anterior or lateral interbody fusion plus endoscopic decompression. We have data about it, but we won't show it. It's only a bit more fancy to show videos. And it's better to start by hybrid fusion before doing fully endoscopic fusion, because they are much more harder at the beginning. So usually we do anterior or lateral interbody fusion, or leaf, A-leaf, whatever, and you can do the decompression if it was needed, and if you need it also if there is the indirect decompression. So of course it depends on the case you have to do. It's for training and be better on it. So on the series we did X-leaf, A-leaf or X-A-leaf plus posterior decompression, so you have many possibilities. So think only anteriorly for your interbody fusion, and then you can go posteriorly for the decompression if need for foraminotomy or for laminectomy, whatever is required. So you can do all of the panel, adding only the posterior endoscopic approach that you can also do in lateral position. So if you do X-A-leaf or leaf, X-leaf, and the posterior endoscopic decompression in the same position.
The question after this explanation is, do we have an advantage to realize a full endoscopic fusion, and is it a game changer for the fusion?
So the AO spine doesn't call it full endoscopy because they classify as assisted endoscopy, but I would ask an orthopedic surgeon doing knee surgery if it's assisted endoscopy. I think it's completely endoscopy. So let's see how to do a PLEAF or TLEAF. Actually, you have the same possibilities as in open surgery because you have your two hands. So usually we do the 4 incision for the screws, of course, and we use the 2 on the right or on the left to perform the arthrectomy and the disc preparation and insertion of the cage. So we target the docking point, then we target the facets, and we proceed with osteotomies, and we have a huge possibility of doing osteotomies to have a large bone graft for the interbody fusion. And here is the technique of one of our friends from South Africa, the small pieces with the osteotome or with the bone scalpel to have a lot of graft for the fusion. So here you have an example. Here, so we are on the left side of the patient, so you have cranial, caudal, medial and lateral. This is the lamina of L3 in this case. Here is the piezoelectric, so a bone scalpel, to perform the osteotomies, so we can cut many slices of bones to don't lose it, because usually in newbie we use drill, so it's a loss of bone for the graft. So you can see all of these sagittal cuts, also to allow the possibility to put it out of the patient, because the incisions are not so big. So you perform all of your osteotomies of the AIP first, then you discover the SAP here, and under radioscopy, to don't break the pedicule, the interpedicule, you do the cut on the SIP, and then you can do the compression if you need, of course. So it could be PLEAF, whatever you want. Here you have the disc. Then we prepare the disc. I will go a bit forward. So you see the 360 decompression, and the work into this space. Here you can see that you have a powerful tool to prepare the end plates, and you see the end plates even better than in the AIF, because you are inside, you see much better. You can be sure that you won't break it, actually, before the insertion of the implant, of course. And with the huge saline solution lavage that you are doing, there are data that show that you decrease the infection rates, you decrease the pseudoarthrosis, probably because you don't have any single germ into the field, and then you can perform the implantation, and at the end you have the 4 incision of your screws, and nothing else. And it decreases a lot also the pain for the patients. We can do revision surgery, so in complex patients, you don't have to remove everything if you need a decompression in a foramen, for example, in this one. And we can push forward and treat also adjacent segment disease with it. And we are probably the heirs of our past.
And maybe all of the surgeons can see in consultation this kind of cases.
So what do we do here?
But maybe a liberation, maybe an extension, maybe both of them. We like the controversy and we like criticisms, and we would like to engage a debate in your mind now. Just a usual case we can see in consultation, and you can see that it's so easy to go in the fibrosis. You can see the fibrosis on your right as a cutout part, and you can see the superior lamina. In all the surgery with UB, you have to find a bone contact. It's the talking point. If you don't have bone contact, it's impossible, or you don't have to realize the surgery. And you can, if you want, just realize a liberation, because you will be able to realize after a fusion. Always for the controversy, we began a study with a prospective review, 22 patients with adjacent segment, and the average time was 60 minutes with an hospital day of 1 day and a few complications. 2 dural tears. We have 80% of improvement, but we have also 3 patients with back pain, but morbid obesity patients, and then old patient, and this patient with herniated disc after the decompression. Let's go to climb.
So we proceed with climbing into the spine. We can proceed then with cervical foraminotomy, microdiscectomy, and other. So this is the setting of the OR.
And the same like you know every day and you do every day. It's a prone position with a Mayfield, with an endoscope. The difference is the ergonomy of the surgeon and of the nurse, because you can see your face, and after you will have maybe the same viewpoint like in lumbar surgery, and you can realize this kind of surgery. It's a normal speed.
It's not, come on.
Very fast.
Joseph.
So here is the example of cervical foraminotomy, which is the easiest one to perform before laminectomy or microdiscectomy. So we target the docking point, which is the V point, so the termination of the facet joint into the laminas. And then we have to drill a bit of the AIP and a bit of the SIP, and it's done. It's the same as it's done in monoportal surgery, and the same it can be done also with the tubular. So this is also with the bone scalpel, but usually we use the drill, the high-speed drill or the arthroscopic drill. So you remove a bit of the AIP.
you use neural monitoring for this?
For anatomy,
Yeah.
for myelopathy, yes.
Okay.
For laminectomy. For you, on the monitor.
Neural monitoring? No.
It's my nose with our hands.
For spinal cord, yes.
Yes.
But for frontals. So here you have the AIP that is being drilled, and then you drill or you remove the SIP, and you don't have to open the membrane that is around the nerve in cervical. That bleeds a lot when you open it, and then you finish. You can see your nerve roots completely liberated.
We didn't speak about this, but the big challenge in UBE is to manage the pressure of the water, because you can put an ultrasound, like in the endoscopy, and it's not the same parameters in lumbar and cervical.
And then we can proceed with microdiscectomy, which is a bit harder because we have to proceed deeper, and in Biportal it's much harder.
Yes, it's another case, a classical case with C7 pneumonia on the right side, a young man, and we would like to avoid an NCDF. Maybe we can realize an NCDF later. And the advantage of this technique, we can use a hook, it's a bipolar hook, and we can remove, if you want, an anti-disc with this tool, and we can also realize the cauterization of the ligament. Maybe, we don't know, and we would like to know with the future studies to avoid recurrence. You can see it was the day after the surgery. You can see the working space here, and 2 months after, you just see this kind of image.
And we can proceed with laminectomy. As said Joseph, there is a point with the pressure of the saline solution, so we have to be very careful when attacking the spinal cord with UBE, which is very different with monoportal surgery, where the pressure is not a big matter. So you target the same thing. Of course, the indication we can discuss about it, but it's only to show. You can do single level laminectomy, so targeting the yellow ligament, and do just a bit of laminectomy on the cranial side and on the caudal side. And then you will very easily, like in lumbar, even faster than in lumbar, you will finish into the contralateral side easily, going over the top and below the. Sorry. I proceed with the 2 levels. So here, of course, there was an anterior approach first, but the safety posterior operation after. So you can target 1 lamina and do 2 or 3 levels. 3 levels starting to be hard with the 2 same incisions. You can see here the lamina with the yellow cranially and the yellow caudally, and you can do your cuts. This is the medial cut, so the one that will bring you to the over the top, and then you can do slices, you can drill, you can do whatever you want to be the safest possible. And you're very easily to the contralateral side, so you don't need, you can add screws as well. You don't need to drill a lot to be to the other side.
You put screws in the same endoscopic hole?
Yeah.
Just the 2 little holes?
Yes.
On both
it's
sides?
very difficult.
I bet.
There is
on both sides?
Now you have to do 2 other incisions.
And you plus the rods to that?
Yeah, but this is I mean there is
not for any of you.
There is not the matter of the instrumentation for it.
Yeah, not yet.
You should percutaneous, so I won't do it anymore.
Yeah, it's hard.
To continue with the controversy, it was an OPNL, not a young man. And with the newbie, we can keep the possibility to realize after complectomy, but we decide to realize circumferential decompression. We first, on Wednesday, the laminectomy, and after 2 days after, anterior decompression. Another case, another myelopathy, and we begin also by the posterior approach on Wednesday, and 2 days after by the anterior approach.
And then you can proceed with dorsal microdiscectomy for soft or hard disc herniation. This one is a soft one. And the highway to the disc is the foramen in endoscopy. Whatever it is biportal or uniportal, you don't have to drill even the rib or something, so it's completely changed the game regarding a thoracotomy or a posterior costotransversectomy. And you can do whatever technique you want, the caving technique, doing a bit of drilling of the posterior walls to go below and to be very tangential. We are very tangential below the dura. So, because we use a 30 degrees, so we have a distortion of the field of view. You can also do dorsal laminectomy with the same way as we do in cervical or in lumbar. We can treat our complications, of course, because we do have, mostly at the early beginning of the learning curve. So you can have dural tears, and usually patch of tachosil save you for doing revision in open or in micro. The postoperative hematoma is one of the most frequent complications in the first 100 cases of the learning curve. We can treat it by the same way. And we can add the complexity to your cases. So when you start to do endoscopy, you think only in endoscopy, and you feel already that you will feel better in endoscopy than in open or in micro, because this one, for sure, there will be a dural tear, and in endoscopy, it won't be a problem. You will see better than in micro or in micro. This case of C1, C2 spondylolisthesis, a very old one with already a fusion into the facets. When you think open, you will say I will do arms or occipital-cervical fusion as well, but you can go only endoscopically and do the laminectomy. It doesn't work, sorry for that. You can do also one piece because you don't have the spinous process, so you can go from left to right, from one sulcus of the vertebral artery to the other. Sorry that the video doesn't work. And at the end you have the decompression, a very wide decompression of the C1 arch, and the patient moves the head immediately and can go back home because you won't care about, you won't have any big troubles. Then you can proceed cranially.
Yes, we can also realize cardiac malformation, we can realize nostotomy, and we can also realize a tuberotomy. I don't have the image. We proceed to the technique with an navigation to see the nostotomy realized during the surgery. And we have this kind of image directly after the surgery, and we have no. We are just at 2 months after the surgery, and we are waiting for the result. But for the moment, she's good.
You see the wide decompression with the body work. Then you can push forward. You can do intradural tumors. Like neurinomas or meningiomas. You will add wider view to the field, but at the moment there are no instrumentation adapted to it. So you can do a three-portal approaches, one hander with the endoscope and two hands working into the field, like in laparoscopy actually. But the water is a big mistake with the urinomas, they push it. So I don't think I will do it again. But the patient is very, very well. She was a morbid obesity patient with a lot of comorbidities, so I wouldn't have loved to have infection or dural or leakage after surgery. So the patient is very happy. I'm not. I was tired. I'm tired of the surgery that lasts 4 hours. That's too much for this kind of surgery. But to see that you can proceed with the indication, and in the future, for sure, it will be feasible to do everything. It's like moving into the belly. So with UBE, you don't touch the boundaries, you completely change and deeply change the way you think spine, you adapt your strategies. We can have a big talk also on sagittal balance before and after UBE decompression or endoscopic decompression. So this is the point. And of course there is a big travel to do. The learning curve is tough, so we have to start from the beginning, at the beginning of the journey. And the Dunning trigger effect, I think everybody knows, is a big point in the surgery. And the Biportal technique is not linked to the industries. It's a surgeon-to-surgeon technique. So we don't have bias about some kind of materials. It's not actually it's not control. It's not versus monoportal surgery. They are complementary, and doing both is probably the best way to do endoscopy in spine. And this is the community of SRC.
We are proud to present our friends because SRC is a group of friends, and the most important of this group is this community talks, meetings. And we created with some European friends, European Society of UBE.
Thank you.
Unbelievable, extremely impressive. I think you guys are going to change the world of spine, 100%. It's, I agree with what Bassel said before, in that some of these open surgeries we do, it just makes no sense. It's like doing open knee meniscus repairs or open shoulder rotator cuffs. Nobody would dream of that. And so I think this is where we're going. And I guess I would just ask you, do you have visiting surgeons that can come see you from around the world and learn your techniques? Because that's what we would hope, is we can send some people in the room to come learn from you.
Yes, with the European Society we are creating education programs. We already receive many visitors, but we are creating education programs with step-by-step multimodal ones. Usually we do Joseph, me and others, Guillaume Longeon, many of the Spine Society. We receive the visitors, then train on simulators, see live surgery, they train again, then see, they train. And
to be honest, the masters are in Korea, in South Korea. They invented the technique, and we began just 2 years ago. But it's not difficult to learn this technique, but we have to put our elbow on the side of the road and to become a new resident and to learn a new technique. And after it's too easy because it's the same surgery, and we have the experience of the spine surgery. It's not different.
Yeah. I mean, Joseph is very humble. In Marseille, he has four guys are coming every 2 weeks, and he organizes the hotel room. So it's an industry for Joseph. No problem with that. If you want to send some people there, yeah.
It's for my mom.
Yeah.
I think it was a fantastic talk. Thank you. I mean, really pushing the boundaries here. So I do both uniportal and biportal. Do you do that as well? Do you still, for those foraminal discs, for some of those calcified thoracic discs, do you still go transforaminally uniportals?
Just do a bit, just a bit.
Just a bit.
But probably for the discrimination, I feel better. I think it's quicker and better with monoportal transforaminal. But newbie, I think you know it, cover all the field. I mean, you can do a cervical or lumbar dorsal in the same day with the same approach, the same steps and everything. So.
I think what's nice about the biportal is it feels like normal spine surgery, right? Like the uniportal is like a completely different thing, where the instruments are coming through the tube. Like biportal, it looks exactly the same as you'd be seeing it through a tube. And I think it's a really easy, I mean not easy, but like it's a natural transition from a tube to doing biportal endoscopy using both hands. I think part of my early struggles, I'm still in my early struggles for this, is like the simple things, right? Like how do you, like, in terms of like pump pressures, in terms of like hemostasis, in terms of like how do you not create a snowstorm when you're burying the lamina? And it seems like you've developed different strategies for that using bone scalpel. I'm just curious if you could talk to some of the very early learning curve of doing this.
He does use the pump, I don't. Maybe half of the surgeon use it, half of the other doesn't. But it's not a matter of pressure, actually it's what the Koreans, because we have been to Korea, we have been to Turkey to train, and the master told us, and actually it's the case.
You sometimes put drain?
Yeah.
I never put drain.
It's a matter of flow of water, it's not a pressure. You have to have a continuous flow. If you don't have it, you will have high pressure.
Do you always have we can talk more later on for everybody. Do you always have an outflow cannula, or do you ever use no outflow?
Yeah, if you don't have an outflow, it's difficult to manage the pressure.
But we don't have measurement of the outflow pressure. So it's only what you see, so it's not, also when you use the pump, it's not a closed circuit, it's not a real pressure you can see on the pump.
And it's a popular surgery because you don't have to select your patient in consultation. Everybody can have the benefit of this kind of surgery, and you don't have to just select 15% of indications from a uniportal. It's cheaper than monoportal. It's a popular surgery.
And this is a very good point, that in uniportal we select patients, we cannot do everything. With biportal you can just convert your activity. We both convert to our posterior surgery into full endoscopy, in the way of newbie, but except for deformity.
But we continue to fuse, we were tubular surgeons, we like Elif, we are not just in the UV world. For us, the UV is just a game changer for the decompression, for the open or mini-open without instrumentation.
The patient awake? And the patient's awake?
Usually I do it awake.
Who makes the instruments that you showed in the videos?
Sorry?
Who makes the instruments you showed in the video?
This one, I think we both have phones.
With the triple With the triple phone?
What company?
Yeah, what scope do you use, and what do you use for cannulas and like the instruments?
Usually it's all bones, Chinese, or Endovision, Koreans. Then you have others. Now every industry of monoportal are converting also into biportal. So Max, Rivo, all have, they hide it because it doesn't bring a lot of money, but they all have it.
The material is the same like for the knee surgery. Although we use every day maybe 80% of the material is from Florida. But they don't have the label for the radio frequency in the spine. And we have just the radio frequency from China.
Great.
1980s, we did the first PVCR surgery. So this was actually published at COR. At that time, so actually Dr. Armstrong, so I think he was a previous president of NAS, so he was a Canadian guy. And then he trained a lot of surgeons also in our department, so we have lots of collaborations in this time. So
this is actually linking back to 20 years ago. So that was quite interesting. So this is my mentor. So he is a fellow of Chinese Academy of Engineering, and also he initiated the Chinese Orthopedic Association, we call it COA. They are like around like over 30,000 registration every year for the association, for the annual meeting. So we're gonna have the annual meeting at December, so that's the reason why I can finish the tour at the end of November. So I'm having a tour around the country, different centers, spy centers around the US. So they have lots of discussion, so I was not there at that time, but they have lots of discussion about different classifications of AISs. So we also have our own classification, we call PFC classification. And then they have lots of discussion and idea exchange back to that. So this is the current situation. We have like 132 beds. So this is the whole like department for like physicians and nurses like that. So this is the current chief Terry. So I'm the vice chair of the whole department. So we have like spine, trauma, sports, like everything. So this is me. I'm the vice chair of the department now. So I actually took a different pathway for me, I think, because after I graduated, the graduation took kind of around 3 or 5 years to do research a little bit, but in the recent like 10 years, I'm kind of mostly on clinical. So I'm the current president of International Consortium Spinal Genetics Development of Disease meeting. We're gonna have the annual meeting here in the early of November, and then SRS. So I'm gonna share some interesting pictures in case that you know we are quite open to everybody. So in case there was kind of SRS traveling fellow, every traveling fellow program, they're gonna visit our hospital. This is back to almost 20 years ago. Peter Newton, I don't know if you can recognize this faces, but this is my chief, my mentor, my research mentor. And then Charlie Johnston, he won a big like prize during the SRS meeting this year. And also they're gonna initiate another big prize for him during the PSS meeting. So he brought the team to visit us we had lots of discussions with the peace kind of field. So this is 2005. You can see the Sukan Shop right here, and then this is a lot of stuff around the room. They have lots of discussion about scope research deformities. 2009, Dr. Lenke was there again. Boachi, Johnston, some other guys. This is the first actually China SRS international conference. We organized this back to like more than 10 years ago. This is 2015, the SRS Training Fellow, Dr. Beiruz at Barnia, Yazid, Chop, so Chop physician in Scotland. And then back to 2018, Dr. Sponsor and Dr. Steve Glassman. So just prior to pandemic, we organized this kind of international meeting annually. So Peter Newton, Dr. Schafferberg, Dr. Lenke, and just Chen Chen McIntosh joined this meeting. So we actually initiated a project, we call it DISCO study. So basically we are trying to integrate the different concept of not only orthopedic physician but also scientists, a different work and a different kind of AI stuff. And so basic research, we are leading the medical, like a multi-center study for China for like we have over 30 centers. We're going to do the registration along the year. So currently we have over 20,000 kind of not only spinal deformity patients, but also patients or family members around the country. So we're trying to use the AI technology to initiate some of the program. So I just give you a little bit of concept. So we did do phenotyping for all patients, meaning that there are lots of associated comorbidities that hadn't been found previously. So as a result, we found that there are like over 50%, 55% of the congenital sclerosis cases, they have associated comorbidities that hadn't been found previously. There are some of the associated comorbidities around the body. So kind of intraspinal heart problem. And this is multi-model data, which we spent more than 10 years to establish this like ICD and molecular diagnosis and kind of long-term follow-up. So we around all the 30 centers, plus 30 plus centers around the country, they are using the same criteria for we have established in like 2 years. So we have multi-center phenotype translated this into English. So kind of imaging has some of the growth periods and sample kind of biological data there. I discussed this with Dr. Mike Kelly. Mike Kelly, when I visited UCSD back to like 2 months ago, so it seems like they are very interested in this and also involved in the AO spine knowledge further now. So we have lots of platforms, but just to summarize of all the platforms we have developed by integrating the AI technology into diagnosis and clinical treatment of patients. We also have a semi-automated cup angle measurement that is used. We use it for every case for measurement of different surgical and ground analysis. So this is the strategy we use. We have clinical data, all of this phenotype data, photos, AI-based analysis, and then for scholars, we just focus on deformities like clinical and research things. We are also leading the national screening project for AS, like sclerosis screening. So I can show you some interesting cases because we are talking about clinical things today. 8 years old female, so there's a severe congenital cervical kypho. There's a long creeping compensatory curve. This is bending X-ray. This is the CT scan. So you can show, you can see this kind of severe hemming around the cervical thoracic. This thing we saw from the anterior part. This is kind of CT reconstruction of the vessels around the deformity. So I don't think we have enough time to discuss, but I will show the result. Just in case that you have this kind of feeling, so what we do. So in the first stage, we removed the 3 hemming at the cervical thoracic part, and then this is the immediate follow-up, like 6 months. And then we did a growing rod past the compensatory curve. We fused from C4 to L2. So this is not all my cases, but I inherited some cases from my mentor and my research mentor. So this is 5 years post-op. You can see the fusion of the CT from the CT scan and long-term follow-up. So this is a growth appearance of the patient. And this is another case, 5 years old male, also a little hemming at the apex of the deformity. So you can see this kind of severe, like hemming, spinal fusion and also rib fusion around here. Then actually we did the 2-level VCRs and the short fusion with a growing lot of capacity compensatory curve. This is pre-operation, immediate post-operation. This is the post of our first lengthening, and then this is 4 years post-op. So you can see we still lengthen the lengthening to keep the growth of the spine and kind of controls the growth of the curve and maintain the balance of the spine.
Is this like Schiller technique?
No, it's
active.
Traditional.
Traditional,
Yeah,
okay.
yeah. So this is kind of active over like around 8 years.
Wow, yeah.
So this is 8 years follow-up. So you can see the patient is still like coming to the maturity, and the coronal and septal balance was well maintained. This is a growth picture when the patient was 5 years old. It's 14 years old. So this is a 9 years old. So there's so in terms of the besides the 4 rods, sometimes you use the 6 rods technique. Very severe like severe kypho scoliosis. 6 years old male. So this is a CT scan. Seems like early onset scoliosis, and there's no obvious like structural deformity. We did in the first stage we did T11 VCR with the mesh case there, and then short fusion and the growing rod past the compensation curve. And then after that, this is a kind of demonstration of the 6 rods. You can see these are 4 rods for the 2 rods for the fusion and 4 rods for the growing rod. So this is, you can see the restoration of the kypho right here in the thoracic spine. And this is a sequential follow-up of the lengthening. And this is 3 years post-op, first operation. This is kind of 4th growing rod extension for the patient. So yeah, this is another case. So I just, but sometimes after the 4 years follow-up, you can see the spine. The mentioning of the chronocentric balance of the spine, but remove some of the rod to give enough growth for the spine. Another case. This is another case very severe, like kyphoscoliosis. I just show another case for a 6-rod technique. This is a pre-operation X-ray of the patient. You can see there's cerebromyelia of the spinal deformity, which we observe. We commonly observe. We usually see during if we do MRI for all the congenital scoliosis patients, we can see 1/3 of them have intraspinal deformity. And then this is also 6 rods. We do a VCR, the apex and growing dot. You can see the kind of rotation of the thoracic spine radius. This is a medial post-operation. And then another one is a 3 years old female, very severe unbalanced shoulder. This is what she looks like for the X-ray, and this is the new film CT scan. And we actually also removed did a VCR the apex for short fusion and the growing rod. This is another demonstration of the 6-rod technique. This is what the patient looks like immediately post-operation. The sequential follow-up, we did do a revision because previously we only used the 2 screws for the anterior and upper part of the anchor, but we revised it to make it another 4 screws there. And this is sequential follow-up for the patient like 7 years later. This is what she looks like when she was 3 years, and this is what she looks like 10 years, like 7 years later. This paper was actually published at GBGS last year for the kind of dual growing rod and apical control technique for treating arteriosclerosis. And Dr. Johnson also gave us a commentary on that application. And then I just show a little bit of the things we recently do. And then, so this is another like 11 years film. This is some of the cases that I did when I just came here over 1 year ago. So the patient has very severe track shift. Right? There are like 2 hemi right here, hemi 5-1, and another hemi right here. There's a publication of the patient. She can only walk like 100 meters. So there are lots of physicians, lots of discussion, not only in our department, but also around the country, how we can treat her. So, so this is a kind of fulcrum on the traction. Actually, some physicians will give her like traction, some kind of staged operation. But this is a CT scan that definitely shows the hemi right here and another big hemi at the lumbar region. There's nothing in the MRI scan. So this is a gross appearance of the patient. You can see severe trunk shift. And there's qualification due to the fraction. We call it fractional curve, but actually it's a curve caused by congenital. So the thing I did is I put, so we have discussion about S2 ALA screws there. So it started S2AI, because S2AI really passes the ISA joint, but S2 ALA I use is right here. So these are the 2 screws at the L5. These are 2 screws at these are 2 screws at L5. These are 2 screws at L1. These are 2 S2 ALA screws. I will show the X-ray later. This is not going to this way, but going to that way. I can do like around 35 millimeter length or even 40 millimeters. I put 2 screws at ilium. I use the kickstand technique because I put 2 screws at the 4 and another screw at the hemi. I use 2 screws to do the kickstand technique, so to correct the chronal balance. And then what I did is the distraction at this side, so by using the 2 rods and then compress a lot at this side. I can do like more correction, but the neuromonitor told me that there's still there was a little bit of nerve change during my correcting more, so I just lose a little bit. But this is the final imaging, what it looks like during the operation. I removed the hemi screw right there, but I maintained the I2 ALA screw. I will show you later. I compressed a lot of distracted off this side. So this is what the patient looks like pre-operation, immediate post-op. You can see the correction of the kyphosis of the lumbar curve there. And then, so lots of discussion whether the patient can balance herself. This is the immediate post-operation of the patient. So this is 3-month post-operation follow-up. You can see the patient was balancing by herself. I just did very short fusion, right? I didn't fuse any SI joint. I didn't go down to the T10 to pelvis, right? But as to ALAS rule, I use this in this trajectory without any impairment of the SI joint. And this, you can see the match case there, and this is 3 months post-operation. You can see the maintenance of the lordosis of the lumbar sacrum region. This is the gross appearance of the patient 3 months follow-up. So it's still, I can still follow up the patient. Hopefully, I can show you later maybe in the future meetings. You can see the lumbar lordosis and the resolution of such values. This is the last case, I promise. This is a 15 years old female, kind of traditional, like we call it idiopathic, but it's not idiopathic because sometimes the patient suffers from osteopenia, vitamin D deficiency. It's not a crazy curve, but what are you going to do for the patient? But actually, I would like to know that what I did is just remove some of the discs at the apex. I did 3-level discectomy. Because I do both peaks and dots, I'm very comfortable to remove some of the disc for the case. Adolescent case, there's nothing in the MRI. So this is a pre-operation. You can see this small feature. You can see. So I did 3 levels discectomy, and then I kind of corrected all the deformity from the coronal and the restoration of the kyphosis right here. I didn't do any PSOs. I just did 3 levels of discectomy. This is really powerful. I think this is another strategy to control the apex. We call it apical control technique. And then I just do the fusion.
Did you put a bone graft in the disc?
Yeah, just a little bit.
And do you go from the right side from the convexity?
Actually, I put the left rod first.
You put the left rod, but how do you go into the disc?
From the convexity.
Yeah, from the convexity, because it's facing
yeah, it's easier. Yeah.
And then you do the left rod.
Yeah. So I did lots of derotation. I use a kind of hybrid technique to in situ, like derotation, segmental derotation, and translation. So I use this transfer technique. So this is a medial post-op. This is the X-ray of the patient. I think this is a 3 months follow-up because this is the cases that I did earlier this year. So I want to have 3 month follow-up. The patient, this is a cerebral balance. I think the patient is still balancing because the pelvis, the right side is a little elevated. I think as long as I give her more time, I think she will balance in the future. So thank you so much for having me here. So I'm really grateful and see lots of amazing things happen in the OR at Brown. This is my great pleasure to hear, and I'm happy to see these friends. And you're welcome to join me in Beijing and in the future. Thank you so much. Thank you.
Back friends
and you still do.
Yes.
Survive.
Well, Dr. France, and he's now in Périgueux, and he's part of the Bordeaux team, at least locally, and he's, I'd say, the master of building bridges around the world. He was part of building about 70 surgeon society, and he always traveled around to keep it going. So thank you for coming to visit the team.
Thank you so much. Thank you, Alan, and thank you for giving me the opportunity to talk about building bridges. Because first of all, America, I do love you since the beginning. So it's been the 10th anniversary of this research fellow year. That was a crazy year. That was the craziest. I mean, you come in New York University Spine Research Institute, and you come out like totally different. You just changed my life. And as you can see, that's the research that I want to perform. It's fun. It's, it's a lot of work. It's work hard and play hard, but it's very, very rewarding. We were like a family, and it was like 3 nights a week, study designing in sports bar with beer. It was like partying a lot, being with François. You can see that Frank still has the longest. Yeah, it's Frank. But it was like a huge opportunity, and this is only in America that you can see
people from Israel, Russia, China, France, put their ethnics, put their religious, put their politics outside the door, and just be like one man about patient outcome.